How are we all doing? Right. So just a quick one. I will be introducing like 15 probably relatively new concepts that probably a lot of people won't have like done in university or start of dentistry. So just as a heads up, if you have a pen or paper, jot some stuff down as we go along. It might be easier just than trying to recall it after the lecture. Okay. I think Niji, you said that this was going to be put back on YouTube.
Yeah.
That's fine. So that'll be there for you as well. And if you need to get in touch about anything, I'm more than happy to go through some stuff. Okay. Right. Okay. So the first question, what is biomimetic restorative dentistry? And so realistically, it's respecting the actual tooth and the restoration and respecting the original biology. So you're trying to replicate the tooth from the bottom upwards. A lot of the times in aesthetic dentistry, we only focus on the end result, like the nice anatomy on the top, but realistically, what we want is predictability. And this is what biomimetic restorative dentistry gives us. So allowing a good bonded base at the bottom and working our way up. So that is the most important stage, starting from the very start. So the restorations mimic tooth structure, mimic the actual natural bond strength of the teeth. They mimic the modulus of elasticity and the flexibility within the teeth, and they mimic the stress distribution a normal tooth, i.e. enamel, dentine, and DEJ would normally have. So like I just said, so for a predictive adhesive restoration, and it's the one that is long lasting, a biomimetic approach is a must. And this is something that if I would have learned about in university, and especially after reading over COVID and lockdown into this, I implement this in most of my restorations from now on. So the objectives, like I said, there's 15 relative objectives, starting from how to indicate certain caries, like caries removal endpoints, which you'll go into, certain different techniques of enamel bevel, air abrasion, about bonding, and then about stresses within your composite restorations. Okay, so we'll start off with caries detecting dye. So caries detecting dye, the most publicized one is by Caries, and it's a Japanese design. And what it is, it's a dye that allows you to produce a minimally invasive cavity that has a predictable bond strength. And what the dye does is it actually identifies caries within different levels of structure through the tooth. So deep dentine and superficial dentine. And it also indicates how progressed that decay is. So more deeper dentine, so affected carious dentine, has a lower bacterial load compared to outer infected dentine. So outer infected dentine, due to its higher bacterial load, will stain a darker color, whereas the affected dentine in the actual inner dentine, which has a lower bacterial load, will stain a lighter color. And that's what we'll go into. So like I just said, outer carious dentine. So when you drill into a tooth and that stuff that just literally melts away with your rose head, with caries detecting dye, this will stain dark red or purple. And your inner carious dentine, your stuff that's more or less just over your pulp, and the first few millimeters of that stains with caries detecting dye like a pink hue. And then sound dentine doesn't stain, and neither does enamel. So this is how we can start to see the different levels of decay and the different bacterial loads of actual caries. So this is like a cross section of the tooth we see here. This is our pulp. And then this area here, which we see as a pink hue on a diagram, is the inner affected dentine. And then this is your outer infected dentine. So this is how it should kind of show in the tooth in the pictures I'll show you going forward, okay? So the reason it's important, so these structures all have different bond strengths, and this is why we need to identify where this certain level of decay is. So outer carious dentine, the dentine that with caries detecting dye stains a darker red or a purple, has a microtensile bond strength of only 15 megapascals, whereas inner carious dentine, so your light pink, your sound dentine, and your beveled enamel all have a bond strength of at least 30 megapascals. So obviously, if we can't identify where our outer carious dentine is, then we're always going to have a reduced bond strength in our preps. And like I just said, we need to identify and remove the outer carious dentine where appropriate, and I'll go into where it is appropriate to leave it. And if we don't remove it all or remove most of it, we'll significantly reduce our bonded restoration strength, not only to the enamel, but also to the dentine and the hybrid layer. So this is a picture here. So if you look at the bottom of some of these pictures, these are some key people to go after this lecture and follow on Instagram. So if we take a look at the top left picture first and look at the distal of the 6, you can see here along the DEJ, we have a dark purple area. And as it's removed more, we go from a dark purple area, which was obviously removing the infected caries. And we see here a lighter pink area. And this is the affected dentine, the inner carious dentine. We remove it more. And then here we go. It's more or less clear. And we've probably left a little bit of affected dentine just over where the pulp is. And I'll go into the measurements of where we leave it in the slides coming. Again, if we look at the mesial of the 7, around the DJ area, we have a darker band of caries detected dye. And this shows that we have infected outer carious dentine. And then they're removed, and it's removed. And this was obviously completely removed because it was in the parameters of not causing any problems with the pulp. Again, look at this buccal cavity. The removed are all composite there, I presume. Here, more purpley hue, dark purple. Remove the outer carious dentine, and here it's lighter again, and that's got a resin coat on as well. So they've selectively removed outer carious dentine, which is infected dentine, so they have predictable bond strength. And in every biomimetic restoration, you should really leave inner affected dentine, so the one that's slightly pink, because at the end of the day, we're being as preservative for the pulp as we can be, but still maintaining at least 30 megapascals of bond strength. Okay, so as I just said there, that we could identify areas where we should maybe leave affected dentine or infected dentine, and this is something called a caries removal endpoint. And like I just said, why don't we remove all the caries? Well, we can if it's a very minimal restoration, but in these restorations that have got deep dentine and dentine that's maybe caries that's deep into pulp, we want to maybe have an idea of what parameters we should be leaving and sealing dentine caries in at. And obviously this is for the point of pulp health preservation. So the caries removal endpoint, first of all, enables pulp-friendly cavity preps, predictable bond strength, because we know exactly where we're leaving either infected or affected carious dentine. So we're predictably selecting if we're going to leave an area which might be a lower 15 megapascal bond strength. And it also, like I said, it visualizes where we know where we can seal in the decay we're leaving, and it's a reproducible workflow. So if we know that we're going to work within these parameters, we measure these parameters, which I'll show in a minute, with a BP probe or a Williams probe. And then long as we just continue this workflow from tooth to tooth, patient to patient, we're going to be having a predictable workflow. And then we can recall and see if these methods we're using do work. So how caries removal endpoint first came about was there was an in vitro test of thousands and thousands of molars. And the measurements of these molars showed that there was set measurements that if we were within these parameters, there was more or less zero chance of exposing the pulp. And that's exactly what we want, don't we? How many times are we in dental school or as dentists are we doing a deep cavity? I had one today and I thought, bloody hell, I'm deep here, but I followed these parameters here with these measurements and I didn't expose. So what the measurements are is if you measure with a BP probe, so the top of the black band, or a Williams probe, 5 millimeters from the occlusal, any caries below 5 millimeters from the occlusal, you leave. Doesn't matter if it's affected or infected caries. If it's soft, leave it, because you're going to seal it in, you're at least bonding to it, and you're not going to expose the pulp. And then again, 3 millimeters measurement from the adjacent or marginal ridge. So here you see the lower 6 and the 5. Measure from the 5's distal marginal ridge inwards. And if there's any decay at the point of 5 millimeters, 3 millimeters in from the tooth, leave it. And as long as that outer ring around those parameters are clear of infected or affected dentine, you're fine, because it will be sealed in. and that's called a peripheral seal zone. And that's what we'll go into now. And I'll give you a minute if anyone wants to take a picture of these measurements or quickly jot them down. So like I just said, outside these parameters, so if you go greater than 5 mil from occlusal surface or greater than 3 mil from the adjacent marginal ridge, caries should be left, because if you don't leave it there, there's a high chance of a pulp exposure. Outer caries dentine, IDC, and that's the infected dentine, should only ever be left because of, one, the reduced bond strength, and two, the fact that it's got a high bacterial load. It should only ever be left if you're doing it to avoid a caries pulp exposure. Okay. So a peripheral seal zone, I just quickly mentioned it then. So when you've done your caries removal endpoint, you've done your measurements and you've left caries within these measurements, you will be left with a 2 to 3 millimeter ring of sound tissue that's completely clear, what you've cleared, like around, you know where they say clear your DJ, similar situation. You've got 2 to 3 millimeter band, like you can see on the picture, of where you're leaving decay in. And that's fine. As long as you have this band round, it entombs whatever you left, and therefore it arrests that decay. And having this band of dentine, enamel, and DEJ allows a predictable bond strength in this area of 30 to 50 megapascals. So you've sealed it in, you've got a high predictable restoration, and you've avoided any caries pulp exposure. So what we'll do now, just move on to a discussion about beveling enamel. So this is a thing for me, this was a new read as well. So originally we're taught to bevel the enamel in case there's any overhanging or unsupported enamel, we should remove it. And that's correct in a sense. So any enamel that's unsupported and has a thickness less than 1 millimeter should be beveled, because when it's under functional load, so occlusal load, especially if you haven't verticalized occlusion, so if you haven't got an ideal occlusion on that actual restoration, those enamel prisms will fracture and you'll lose your bond strength to the enamel. So this is one reason we bevel. However, this is the real reason we bevel. So enamel rods run perpendicular to the tooth from the DEJ. So if this is the tooth, the enamel rods will run upwards for here, and here on the side, they'll run perpendicular, okay? So when we cut, say, a class 1 cavity, we cut a box, the enamel that we are bonding to, if we don't bevel, is the sides of the enamel rods as they run parallel to the tooth. And bonding to the sides of the enamel rods will produce a bond strength of only 15 megapascals, okay? So if you can see on this picture, these long lines is the actual internal axial cavity wall of our class 1 cavity that we cut. And if we bond to this, we don't bond to the most bondable end of the enamel, we're bonding to the side of it, and that gives us 15 megapascals of bond. However, if we bevel our enamel at 45 degrees, we are now exposing the ends of the enamel tubules, okay? Enamel prisms. And this 45-degree bevel is called Boyle's lines, and now we're exposing the ends of the enamel. And this allows us to bond, do our bonding with our resin, in our gold standard bonding agents, and our composite to these enamel rods. And it's been proven that bonding to beveled enamel, the ends of enamel, increases bond strength by double. So 30 megapascals. So even if you can't do any of the stuff that I've mentioned already, if you can't use caries detecting dye, you can't do caries removal endpoint, which you should be able to do without the dye. If you just bevel your enamel, you're doubling the strength of your restoration straight away. Okay. So we're going to air abrasion. So air abrasion using aluminum oxide, 28 microns. So you might see this, especially in restorations where they end up with a quite a speckled layer on the bottom of the tooth on Instagram, or when they've done an onlay that might microabrade the prep and then cement it to the tooth. So what air abrasion does, especially in a direct restoration where you're trying to bond to dentine, it creates a uniform smear layer. So it compacts a smear layer. And then what that allows you to then do is when you use your bonding agents, It allows maximum reinfiltration of your collagen fibers that when you etch, they collapse. So if you compact the smear layer, you can get a stronger hybrid layer. So you're increasing your bond strength to your dentine. Also, what air abrasion does is it removes any unsupported enamel prisms. So microscopically, if there's unsupported enamel prisms that normally would break off again under axial load from the occlusal forces, it means that when you actually do air abrasion to the enamel as well, you're increasing your bond strength to enamel in the long run and reducing the failure rate of restorations. So what it is, it's, if for those who don't know, you attach this to the chair like you would a high speed, fill this bit here with aluminum oxide particles, make sure it's on a low setting, because you can cut through tooth like butter with this if it's on a high one, very low setting, and just literally go over the actual dentine and the enamel of the tooth. And what you can do with this as well, when you bond onlays to your teeth or bond any indirect restoration to a tooth, you should air abrade the base of the tooth you're bonding to, and this will increase the micromechanical retention of your prep and increase your actual bond strength of your resin cement for your onlay or your crown. So this is what I was just explaining. So like I said, prior to cementation of onlays, the fit surface can be air abraded. So in this top right picture here, this is a bio base, which I'll go on to talk about in a bit. And this is what we're bonding to. So this is bio base, which I'll go on to, is the bond layer, a resin coat, and the first layer of composite, dentine replacement. And we should, because with adhesive dentistry working so well now, we should definitely move away from just bonding to tooth. We should bond to enamel, yes, I totally agree with that. But in this area here, if we air abrade composite, we can then bond with a resin cement on top of it with really high predictable bond strengths. So this is what they've done here. And if we don't have air abrasion, then what we can do is we can just roughen with a diamond burr. So if you roughen your prep prior to cementation, then you'll massively increase the micromechanical bond strength of your restorations as well. So next one, so matrix metalloproteinases. So MMPs, what are they? So they are naturally occurring enzymes that are in your dentine. So what happens during caries is your body kind of goes into self-destruct. So when there's a high bacterial load, there'll be high acidic metabolites from the bacteria. And MMPs actually degrade collagen, and they are activated by acidic environments. So when you have tooth decay, the bacteria's acidic environment will activate MMPs. And what will happen with the MMPs is that they will start to break down the collagen. So if you have caries there, your tooth will start to kind of break down itself as such. So this is what happens. In an acidic environment, when you etch dentine, obviously, again, you're producing an acidic environment in the dentine because you're using 37% phosphoric acid. So as soon as you etch, you are activating MMPs. So this is what can happen. If you don't deactivate these MMPs after you've etched, realistically, you're losing a lot of bond strength, because what will happen is you etch, the MMPs will activate and break down your collagen in your hybrid layer, and you'll just lose the bond strength to dentine. So what you should do is cut your cavity, etch, then get chlorhexidine on a cotton wool pledget and rub the etched surface. This chlorhexidine will deactivate the MMPs. Rinse the chlorhexidine off. You still have your etched enamel and dentine. You've now deactivated MMPs, so you haven't lost any collagen in your hybrid layer, and then you use your bonding system and you'll have a great hybrid layer bond strength. Okay, so this is just something, another step that you can add to your restorations. It's a simple one, you don't need fancy stuff. Like alongside the enamel bevel, increasing the bonding by double. This is something after you've etched, in dental hospital or in a practice, get some chlorhexidine, rub it on the dentine after you've etched it and rinse it off, and that'll be increasing your bond strength and longevity of your bond to dentine. So after that, we'll go talk about gold standard bonding agents. So a gold standard bonding agent really is the one that is working the best. And there's three that come to mind especially. So Optibond FL, that should be an I don't know why I put Optibond, but it's Optibond FL. And Optibond FL is a 3-stage system. So etch, prime, bond, and it's a total etch system. So it means that you are doing the etching, the actual bond or the primer isn't doing the etching. So like I said, it's 37% phosphoric acid. Then the prime, like we get taught in university, the prime reinfiltrates the collagen that is collapsed in the hybrid layer, and then the bond. And then the bond is a resin-filled polymerization sequence. And when we cure it, the resin tugs into the hybrid layer, and that's how we get a good hybrid layer. And using Optibond FL, we can get predictable bond strengths of 31.4 megapascals. And that is as strong as we're going to get. That's as strong as bonding to enamel. And enamel in good circumstances, 32. But there has been some in vitro studies of using bonding agents following all the principles we've discussed. Deactivating MMP is Carrier's removal endpoint of actual dentine bonding strengths of up to 60 megapascals. So we should move away from the thought of adhesive restorations are just about bonding to enamel. If we can actually selectively bond to proper dentine using these bonding agents, we can get a much higher bond strength, and it's going to make our restorations last a lot longer, stay on a lot longer, and reduce sensitivity and the pulp's vitality. Second is something called Clearfill SE. So this is a 2-stage self-etch bonding system. So I remember seeing something when I was revising a couple of years ago in dental school about 3-stage systems are better than 2-stage. I think that used to be the case, but now 2-stage systems have got a lot better, especially with Clearfill SE. So being a 2-stage self-etch, it's a prime and a bond, and the actual primer etches the dentine. So instead of a 37% phosphoric acid, the primer is acidic, but with a much lower acidity percentage that etches the dentine. At the same time, it reinfiltrates the collagen, and then you put your bond on afterwards, after obviously light curing each stage. And again, with this, we have bonding strengths to dentine similar to that of enamel. So again, we're having predictable high bond strengths to dentine with these gold standing bonding agents. Third is something called Optibond Extra. I actually hadn't heard of this until I looked it up. Again, this is a 2-stage self-etch bonding system, the same as Clearfill SE. So the resin etches again, and then infiltrates the collagen with the primer, and then your resin light cured bond produces a resin tags in the hybrid layer. What with these 2-stage techniques is quite good is that even more so you're reducing the chance of sensitivity to the pulp because of a reduced actual concentration, acidity concentration. So what you can do with these 2-stage systems is use the etch primer on the dentine, and then selectively etch the enamel afterwards with 37% phosphoric acid. So you've got best of both worlds. You've got a nice strong bond to dentine with a low chance of pulpal irritation, but also a very strong, predictable, nice frosty etch to the enamel. Okay, so why are they gold standard? So there were some studies done on these gold standard bonding agents, and they were done under electron microscope. So they cut the tooth in half, exposing the enamel, the dentine, and enamel and dentine interface. And they were doing bonding tests to the dentine. So they applied different bonding agents to the dentine layer to see what would go on with the hybrid layer. And they found out with bonding systems that there was gap formation. And this was between this area here, so the dentine and the bond. And what they'd see under electron microscope was little air bubbles or little pulls away due to shrinkage in the hybrid layer. And this would tend to happen between 7 to 14 seconds during light curing. And obviously, if you're getting voids in your hybrid layer, in your dentine bonding, you're reducing microtensile bond strength. And this wasn't just happening in the dentine, it was also happening in the enamel. So if we're getting these voids, one, we're losing bond strength to dentine. We're also going to get post-op sensitivity because any shrinkage away from the hybrid layer or the dentine will stress the tooth. It'll increase the chance of marginal leakage because you'll have gap formation under your bond. So it means you're not sealing off the dentine in the long run, causing a risk of secondary caries or sensitivity. So this is why we need to be using gold standard bonding agents, because they found out that gold standard bonding agents, i.e. Optibond FL, 3-stage system, Clearfill SE or Optibond Extra, had no to the least amount of gap formation compared to all the other bonding agents. And this was Hitachi in 2017. So if you want a strong hybrid layer with a predictable dentine bonding strength, that at least the same as enamel or greater, with a reduction in gap formation in your hybrid layer. So strong bonding, no leakage, we need to be using gold standard bonding agents. And this is the most important part. This is what you're sticking a restoration to the tooth. And this is the complex bit. Controversial as well, gold standard bonding agents. In dental school, everyone air dries the shit out of bond. And I've definitely done it in the past because everyone's saying evaporate the whatever it is off the bond and don't till it doesn't ripple and stuff like that. Two things: if it's rippling, you've got too much bond, the bond's too thick, and if you're air drying your resins, you're losing bond strength. So I no longer air dry resins. So there's numerous studies on it, and it's been done by Dr. David and David Alleman that prove air drying your bond reduces the bond strength. So if you air dry your bond, you're increasing something called the oxygen inhibition layer. So what happens is that your camphor molecules, which is your photoinitiator in your bond, actually degrades and it gets turned into impotent radicals. And obviously these radicals can't produce free radical polymerization because you've no longer got the camphor molecule. So this means that free radical polymerization is limited. Your bond can't mature, your resin tags can't go into your hybrid layer, so you're losing bond strength if you are getting air drying your bonds. So what you should do, you should wick away excess. So 2 micro brushes, one to apply the bond, the second to remove any excess that makes the bond look like a river that's flowing over the tooth, okay? And this was further proved by the fact that there was a test done where they air dried the bond and cured it, and they did the microtensile bond strength of this, and this was reduced obviously. But then what they did was put a layer of composite on top. The layer of composite had a different photoinitiator, and that photoinitiator leached into the bond, and when cured again, the photoinitiator from the composite activated the resin tags in the bond, and then the bond had a stronger bond strength to the hybrid layer. So it proved that it was the inactivation of the camphorquinone in the bond, the photoinitiator, that air drying did. So take from this, don't air dry your bonds. So this is a third stage we can do. This is for the simple things, especially in university. Bevel your enamel, use chlorhexidine to deactivate MMPs, and don't air thin your bond, and don't put a shitload of bond on as well. So immediate dentine sealing. So immediate dentine sealing is really what it says on the tin. As soon as you've cut your dentine, don't mess around, seal it with a bonding agent. It's first theorized in 1992 in Japan by Fusiyama. And there was a landmark paper written by Pascal Mane in 2005, proving that IDS, especially in indirect restorations, onlays, crowns, quadruples the bond strength. So if you're not doing IDS on onlays, then you're not doing it right, put it that way. And we'll go into what a biobase is. A biobase, quickly, is IDS, immediate dentine sealing, your resin coat, and a layer of composite. And we'll go into that in a few slides on. Like I said, it's the first layer of all indirect and direct restorations. The biobase is the most important part of the biomimetic dentist's workflow. It seals the bottom of the restoration, and the longevity of a biobase is 20 years at least, if it's done correctly with all these methods. So here are some pictures. So we'll look at the top one first and then the bottom one. So as soon as the dentine's cut, as soon as you've done your onlay prep, your cavity for a composite, you're doing a crown prep, any exposed dentine you should seal, but we seal the enamel and the dentine at this point. So we etch, deactivate with the MMPs, and then bond with a gold standard bonding agent. So here we can see our freshly cut preparation. Here we can see our IDS layer. So etch, bond, and all over this. Again here, we've got our, probably going to be an onlay at some point, but here's our cut restoration, here's the dentine, and here what they've done, IDS layer. So immediate dentine seal, all they're doing is etching, using the chlorohexidine to deactivate the MMPs, and then using a gold standing bonding agent and curing it. That's all an immediate dentine sealing layer is, okay? So like I said, immediate dentine sealing is proved to increase the bond strength of restorations, indirect restorations, by 4 times. And the reason it is because of central masses of restorations, which I'll go on to. If you do an immediate dentine seal of your restoration, it allows the bond strength in the hybrid layer to mature and shrink towards the tooth. You then take your impression, send it to the lab, and then you put the crown on top of this layer. If you don't do this and just cement the crown, the bond will move towards the crown being the center of mass and ruin the bond. So like I said, immediate dentine seal allows you to have a cohesive strength of in the 50 to 60 megapascal range. And this mimics the D&J. So the strength it takes to pull the actual molecules in the D&J apart is 50 to 60 megapascals. So therefore, if we're mimicking this strength, the restoration in itself is biomimetic. Sealing the dentine tubules will obviously reduce the ingress of bacteria. You're using a dentine bonding agent that's gold standard. Like I said, no gap formation, no marginal leakage, no sensitivity due to C factor. And this is another thing. Immediate dentine sealing with a gold standard bonding agent, Optibond FL, Optibond Extra, Clearfill SC, heals the pulp. So old school thought, especially within the dental schools, they say you're close to the pulp, let's put a little layer of Vitribond down, let's put a little layer of GIC to be kind to the pulp. Bollocks. IDS, gold standard bonding agents, heal the pulp. Loads of papers, evidence all on it. And the reason as well is it heals the pulp, it forms pulpal dentine complexes, tertiary dentine formation. And also what happens is you get a bond strength, like I said, in the 50, 60 megapascal range. Whereas with the Vitribond on the bottom of the dentine, the Vitribond's bond strength is only 6 to 8 megapascals. So you're losing out on 4 to 5 times difference in bond strength in that area. So you're more likely to get marginal leakage. You're more likely to end up with recurrent caries in that area. So if people say to you, put Vitribond, unless you've done a very much like a blushing pulp exposure and you need a therapeutic biodentine, but don't use any liners anymore, any therapeutic stuff, good layer of bond, don't air dry it, and you're sorted. So why does immediate dentine sealing increase the bond strength so much? So the reaction in the bonding system to dentine is free radical polymerization. And within the first 5 minutes, you get an 80% production of the polymerization. And then in up to 30 minutes, you get 90. So it kind of an exponential curve. If you literally bond on top straight away, you're going to lose all your strength in your hybrid layer. But if you wait 5 minutes, most of the bond strength has happened and you've got a strong hybrid layer. So if you allow the bond to mature, so if you do your immediate dentine seal, allow it to mature for 5 minutes, the shrinkage of the actual flow of the polymerization within the bonds will be towards the center of mass. During immediate dentine sealing, the center of mass is still the tooth. So the polymers in the resin will move towards the dentine and leave a void-free, high-strength, high micro bond, tensile bond strength hybrid layer. However, if you do IDS, but then bond composite to it straight away, or if you bond any material like a crown to it straight away, the center of mass then becomes the crown, not the tooth. And if the center of mass is the crown, the hybrid layer will get pulled away. The polymerization flow in the resin bond, in the resin layers of flowable, in the composite will move away from the hybrid layer towards the main bulk of the restoration, and you lose your hybrid layer bond strength. And I think it's something, I'll probably put it down somewhere, you lose 80% of your bond strength if you bond to your IDS. If you bond above 1.5 millimeters of your IDS layer within your first 5 minutes. So, like I said, there's something called a biobase, and the biobase is 1.5 millimeters above the tooth, which we can have within the first 5 minutes. So you have your immediate dentine seal, your gold standard bonding agent. So this is what we see here: freshly cut cavity, caries removal endpoint. Here we have a nice glossy immediate dentine seal, and then we have a resin coat. And all a resin coat is a layer of flowable, ideally a low shrinkage flowable composite like Majesty X. And what we do is we put the flowable composite onto only the dentine. Even though we've done the immediate dentine seal on the dentine and enamel, we put flowable composite on just the dentine area. And we spread it with a BP probe to ensure that the thickness is only 0.5 millimeters or 500 microns. And how we know this is because the ball of the BP, if we think back to dental school, is 0.5 mil. So as long as we've just submerged the ball into the resin coat, we know that it's the correct depth. And here we can see again on the left-hand side, this is pre-caries removal endpoint. We have our pink outer infected dentine. It's been removed. May have left a little bit here due to caries removal endpoint measurements, like I said, 3 millimeters and maybe 5 down. And then they've done their immediate dentine seal and the resin coat. So I've been banging on about Biobase, and if some of you may have seen my latest post on Instagram, I banged about it on it there as well. So the Biobase is the immediate dentine seal with bond, the resin coat with a low shrinkage composite, flowable composite like Majesty F or Majesty X, and a dentine replacement composite layer. These three things is something called the Biobase. And the Biobase is the only thing you can do on top of your resin coats, on top of your dentine bonding agent, to make sure that the flow of polymerization is still towards the tooth. So after the immediate dentine seal, like I just said, within the first 5 minutes, we should not exceed 1.5 millimeters above the tooth. So say this is the tooth down here where my cursor is. We've done our hybrid layer with our immediate dentine seal. We've done our 0.5 millimeters of resin coat, and then we've got a 1 millimeter layer of composite. As long as we don't exceed this, then our bond strength to the hybrid layer is maintained and can still mature. And it allows us to reach bond strengths of 40 to 60 megapascals. So here we go. This is the picture. So as the bond polymerizes in the composite, in the resin, in the hybrid layer, as long as we don't encroach past 1.5 millimeters, so the 1 millimeter of composite and the 0.5 of the resin coat above your bond, the flow of polymerization and the shrinkage of composite will be towards the dentine and the hybrid layer. This means it can mature, it doesn't pull away, you're not going to lose bond strength to your dentine, you're not going to have a weaker bond. And this is where sensitivity in teeth happens as well. Because the shrinkage, if you put a big shitload of bulk fill in, or if you bond and put loads of composite in and don't allow this hybrid layer to mature, the shrinkage is just going to be towards the composite, which I'll show you in the next slide. And that's why we get sensitivity. So with this, you don't even need to warn patients of sensitivity because the shrinkage is towards the tooth. So like I said, no biobase. So if there's no biobase and we just chuck in a load of bulk fill or slapping composite, this is what happens. So this is a diagram here done by David Ellerman. Ignore the boxes. So if we just put a shed load of composite in here, the stress and the polymerization flow of all the resin will be towards the center of mass, which without a biobase is the composite. And this ruins all the bond you've done. All the hard work to get a nice bond you've ruined because the polymerization flow is towards it. And the hybrid layer can't mature, so you're losing bond strength. And this is what I mean. If you don't allow the hybrid layer to mature, if you go more than 1.5 millimeters above the bond layer within the first 5 minutes, you lose 80% of your bond strength. Okay, so this is another term, is hierarchy of bondability. So hierarchy of evidence, you understand that. So Cochrane review at the top and expert opinion at the bottom. With this, it's just enamel and dentine. So hierarchy of bondability, so it explains the ability for resin polymerization to occur to tooth structure. So polymerization will happen to enamel at the top. It happens straight away. Maximum bond strength to enamel happens within the first 5 minutes, whereas the maximum bond strength towards dentine takes up to 30 minutes to happen. So this is what happens. If we have a differential between the ability of our bonds, so if we have a differential between one tooth structure having a greater affinity to bond earlier and another tooth structure, dentine, having an affinity to bond later, we're going to get stress in the tooth. So like I just said, so bond formation to enamel happens at a greater rate with an increased percentage polymerization and complete bond strength formation in the first 5 minutes. If you bond to enamel in 5 minutes and check the bond strength in lab, it will be 30 megapascals. If you check it an hour later, it's still 30 megapascals. So there's a slower formation of bond to dentine, and that's why the maturation takes longer. And this is where we need to respect the fact that if we're connecting these surfaces, if we're connecting dentine and enamel together, if we're connecting the hybrid layer and to the enamel straight away with a shitload of composite, we're going to get shrinkage towards the surface that wants to bond the quickest. So this is the concept of hierarchy of bondability. So if we understand the hierarchy of bondability, if we understand that enamel wants to bond quicker and bonds will form to enamel quicker and the bond strength will mature quicker to enamel, and we understand that dentine takes time, we can do something called decoupling with time. And all decoupling with time means is that with time, we decouple the bonds. And we need to understand that we need to decouple the dentine bonds first before we even attempt to decouple the actual enamel. So what we can do to reduce the stress and allow the bond formation to dentine to occur in the hybrid layer is we need to avoid connecting deep dentine to superficial dentine. So if you have a really deep lesion, you want to be just increasing enamel in in very small increments on top of your biobase for the first 5 minutes. And then again, within that first 5 minutes, if it's not too deep, we don't want to be connecting any enamel and dentine together. Biobase, 5 minute wait till that's all matured. And then build your enamel up and do your enamel slowly to the fact that after you've done that, within that 5 minutes has passed, fine, your dentine strength in your hybrid layer has reached 80% of its strength, and then we can connect the enamel. But we need to be making sure that the bond to the dentine in the hybrid layer has matured, decoupled from the rest of the restoration before we start trying to bond to enamel. So like I said before, it prevents the flow of the polymer chains and the composite from moving away from the dentine hybrid layer. If we connect to enamel, it will want to move towards the enamel because its affinity to bond to enamel is much greater. whereas the affinity to bond to dentine is less. However, if we leave it to bond to dentine, it'll move towards the dentine. And that's the principle, hierarchy of bondability and decoupling of time. If we don't respect the fact that we shouldn't bond to anything but dentine within the first 5 minutes, we will lose 80% of the bond strength to the hybrid layer. And that's huge loss of bond and huge chance of leakage and recurrent caries. So dentine replacement. So we just talked about the resin coat on top of the IDS. So that first millimeter of composite ideally should be a dentine replacement composite. So a dentine replacement composite is a composite that replicates the modulus of elasticity of dentine, because obviously dentine has got a higher modulus of elasticity than enamel because it cushions the tooth. So what people have come up with is dentine replacement composites. So there's one currently in the market called Clearfill APX, which is on the bottom, and then there's EverX. And they're both fiber, so fiberglass reinforced composites, and they mimic the modulus of elasticity as the dentine. They also have really good handling abilities, and they also have extremely low amount of shrinkage, so they're not stressing the tooth and not pulling the tooth from all the angles and not stressing the hybrid layer. And it doesn't stress the bio base, like I just said. If we don't have these fiber reinforced composites, just using a normal composite, but being aware that you want to be doing very small 1 millimeter layers, and this will reduce the stress in the composite. I'm going to go on to another lecture in the future on stress reduction, which will cover some more points in greater depth, and especially this kind of dentine, deep dentine replacement. This was kind of one of the, coming to the end of the slides. There's a rule of thought of something called deep margin elevation. And deep margin elevation, again, it's what it says. So if you have a deep margin, you're going to elevate it. So we're replacing deep dentine. So if we look on this x-ray here, we can see a large lesion here, and this is crestal. It's going to be at least 2-3 millimeters subgingival. And that means that we haven't got a predictable bond strength in this area. So let me just move myself so I can see. And deep margins that are subgingival should be elevated with composite. And this goes against probably what we're taught in dental school or stuff. Finish your restorations on sound tooth, but this isn't the case. In areas just gingival or very deep, if you're going to do a crown, don't finish it on the tooth. It's not predictable. It should be finished on composite. Crowns and onlays with deep margins should always be finished on composite. So like we can see here, I'll explain it. Caries here, deep, couple of millimeters subgingival. There's area here, which is probably quite big underneath, is composite. And they've got a rubber dam, a matrix band down to here, remove the decay and put a layer, done immediate dentine seal, a resin coat, and they've elevated the margin with composite. They've then taken the impression. The impression's good because you've got good margins for the lab to work on. It's above the gingival level. You haven't got bleeding. You haven't to pack with bloody retraction cord, and you can just cement your onlay or your crown margins to the composite, because resin bonding to resin is more predictable than a resin or a resin cement or an adhesive or a non-adhesive cement in a subgingival margin. So this is a bit of workflow. So if you look on this picture here on the left-hand side, we can see a tooth that's been prepared for an onlay. This mesial aspect here is deep. It's probably sub or juxtagingival without rubber dam on. And it's been isolated to the fact, and they can see this nice deep margin here. So what they've done here, George Dentist, he's done immediate dentin seal. He's done a resin coat. And then he's got a matrix band around here, probably a sectional matrix, and he's elevated this margin here with composite. So if you look in the middle picture, we're now on composite. The rest of the tooth is on sound tooth, but this margin here, where you normally bond to on the outer ring around the tooth, which is like your crown margin, is on composite. And this is fine because now we've got, this margin is elevated. We've predictably bonded under rubber dam down deep with a dentine bonding agent that's gold standard and with composite. And what we've done now is elevated the margin. We can see where we're bonding to. Then air abrade this prep here on the right hand side, or roughen it with a diamond burr, and then you just bond to it. And the bonding with this can either be with a heated composite or with like what's it, Real X Unisem, or with Panavia. Any resin cement will bond to resin if you air abrade or roughen it. And the predictability of a resin cement or a resin composite bond to composite on the prep is much more predictable and is stronger than you trying to bond an onlay or a crown down in that deep margin that's wet AF. Okay, so this is a picture. So bonding with resin cement and deep margins is unpredictable, like I just said. If we do deep marginal elevation, we isolate. So we isolate here. We do our immediate dentine seal, which is this white band down here. We elevate, so this is our resin coat and the dentine replacing composite. We elevate this margin, so it's now above the gum level. And then we bond our restoration on top of it. And this is predictable. There's a paper here if you want to read. It's called Deep Marginal Elevation, A Paradigm Shift by Pascal Marne in 2012. And then there definitely is another review where it's like maybe a 20-page PDF, which is quite loads of pictures on it. And it explains deep marginal elevation in not 5 minutes. And it goes in more depth than what I can give you today. But just understand that if in a dental school tutors say, or if in practice you're thinking, oh, I can't do a restoration on this tooth, the margins are subgingival, get a rubber dam on, get a matrix band, bond with composite to that dentine, elevate the margin, and then take your scan or take your impression and just bond to that. There's research, there's recalls within the biomimetic community, especially Pascal Marne, Davy Ellerman, of 20, 25 years plus recall with no problems down here. And I was reading something the other day where they were saying, what about the impingement of the biological width? If you were going to bond anyway down there with the crown, you'd be impinging on the biological width. At least if you're bonding with a resin composite down there, you can get some microepithelium attachment, whereas with the crown, you wouldn't get any with the ceramic down there. So it's more friendly to the pulp, and it's also more friendly to the actual biological width. Last little point, I'm on my actual Instagram part for the day. Yeah, I did say I was going to cover ribbons and light curing. However, after having a little think, these may be better suited in the second lecture of stress relief. So I'll quickly cover them now. So ribbon is a Kevlar mesh. It comes like a shoelace. It's about £270 for 3 strips that are about 20 centimeters long. And you cut it with the special scissors they give you. And what it is, it mimics the DJ. It's a stress propagation. So as the tooth is stressed from occlusal load, the stresses don't go directly down the tooth, they propagate through the ribbons. And this means that you're not stressing your hybrid layer. You're more or less effectively dissipating stress throughout the tooth, and it helps you staying bonded, and it reduces micromechanical leakage because you're not stressing the hybrid layer. In the second lecture I'll do, we'll talk about where to place ribbond, how to place ribbond, and how you can use it in onlays to reduce stress, and especially in patients that onlays may not work. If they debond, ribbon means that you're not going to have a catastrophic failure. It's a more predictive failure where you could just re-cement. So this is what ribbon is. So if you look at the top left picture, we have an onlay prep, caries removal endpoint, and an immediate dentine seal. Top middle picture, we have our bio base, so our IDS, our resin coat, and then this is the first layer of composite, but you stick the ribbon into that. and then you cover it because you can't have it exposed. So that's an advanced bio base with Ribond. Again, here on the bottom left, we have our prep for an onlay. Here it's been immediate dentine sealed, and it looks like it's been resin coated as well. And then this is your dentine replacement composite, the first layer, the 0.5 millimeter, the 1 millimeters, which I discussed as part of the bio base. And then they've then stuck Ribond into the bio base and covered. So this is a bit more advanced. Obviously, we're not going to have this routinely, this Ribond stuff. However, fiber reinforced composite does exactly the same job, studies have shown now. So either or both if you can afford it really in practice. But for dental school, I won't be worrying about this. I'd be just trying to get a nice bio base with a bond, flowable composite 0.5 millimeters and 1 millimeter of actual dentine replacement composite within, and allowing that to rest for 5 minutes. Last little bit, slow start light cure. So this can be, again, another one in the stress relief lecture. So we want to do slow start light curing. Slow start light curing prevents rapid polymerization that could stress the hybrid layer. What happens is if we rapidly light cure and don't do a slow start, the actual chains within the polymerization of the resin and the composite can be stressed due to unorganized formation. A slower start light cure enables proper straight formation of polymerization of polymers, of monomers into oligos into polymers. So this is what we should do. And if we do a rapid light cure and blitz it, we'll get gap formation. So what we say, there is some technical modes for this, but 20 seconds on, if you have a lower mode, you use a lower mode. So 20 seconds on the lowest mode, 10 seconds off, and that's called a dark cure, you're not curing it, and 20 seconds back on with the highest mode, if you do have a high mode, and then that allows the full polymerization. And then the reason you do this is because there was no difference in polymerization stress as such, but it showed that there was less failure with a slow start, but you needed the high start at the end to increase the temperature within the bond to get the full polymerization. But it's just something to think. If you have a setting on your light cure, which is a slow start, which normally looks like a graph that goes up slowly and then across, use that. So that's it really. I'm just going to discuss the next maybe 6 pictures. It's a cavity drawing, not by myself, by David Ellerman, and it discusses a lot of the principles that we've just gone through. So here we have a cavity, a class 1, 4 millimeters across, just because I'm going to say it's 4 millimeters, say, but 5 millimeters deep. And that's because we're not going to impinge any greater than the caries removal endpoint of being 5 millimeters deep. Okay. Here we then have our caries removal endpoints. We remove the caries or left whatever caries is there, and we have our peripheral seal zone. So the peripheral seal zone, like I said before, being an area of 2 to 3 millimeters of a band between the end of the tooth and the caries removal endpoint, around it, above it, which is free from caries and cracks, but cracks is in the next lecture. So then, like I said, we have our caries removal endpoint, our caries free zone, our peripheral seal zone. We air abrade with the 28 micron air abrader, if we have it, and rinse for 10 seconds. And we air abrade the enamel and the dentine. What we then do is our immediate dentine seal with our gold standard bonding agent on all our dentine and enamel, and cure it with our slow cure, 20 seconds slow, and then dark, and then another cure, okay? And then here we talked the second layer of our bio base, resin coat, and we do a 0.5 millimeter or 500 micron layer, which is just the end of the BP probe, and we just coat the area the dentine would have been in. Okay, and then this black layer here on the left picture is now mimicking the third layer of the bio base, and that is the dentine replacement, which is the 1 millimeter. So the IDS, the resin coat, and the composite is the 1.5 millimeter bio base that we don't exceed within the first 5 minutes. And this, in this instance, is APX, which is that composite, which I said is resin fiber reinforced, but it doesn't have to be. then we look on the right picture. As soon as we've got this bio base and we've allowed the bonds to mature in the hybrid layer, we're good to continue to build this deeper dentine. There is a school of thought. I know in the dental school we are taught to do incremental build-up, which is horizontal. But there's a school of thought that if you're doing thin 1 millimeter bands, horizontal, not even incremental, then what you're effectively doing in that is reducing the C factor, the configuration factor within your class 1 restoration. And instead of bonding to 2 sides and having a C factor of so 5 unbonded surfaces in a class 5, there are 4 walls on the base, so you'd bond to the base and the wall, which would mean maybe you'd have a C factor of so it's bonded to unbonded, so 2/3. Whereas if you're just doing 1 millimeter layers, you're effectively just having a very flat layer and bonding to one surface. Even though you're semi on the walls, the fact that they're so thin 1 millimeter layers, you've only got a C factor of less than 2, so you're not stressing out the actual tooth. But that's for another lecture. And then here, okay, on top of our dentine, when we've only bonded to dentine, we've followed the hierarchy of bondability. We've decoupled our dentine bonds with time by only bonding to dentine in these first 5 minutes. And if this is deep here, we do this dentine and wait another. Then we bond to our enamel, because the enamel would have otherwise sucked or pulled the restoration away from the hybrid layer. And then we do our enamel last 2 layers at the end. Right, I know that probably was a lot to take in, but thank you for listening. I'm open to any questions, and we'll do a second lecture at some point on more detail on ribbon, more detail on deep dentine replacement, and on stuff like how to assess teeth for structural problems, so isthmus width, cusp width, when to onlay design, how to bond onlays and onlays versus veneer layers. That's some of the objectives will be in the next lecture. So thank you. Over to Niji, I think.
Yeah, thanks for coming, Alex. That was a really good webinar. I think just about everyone that came on stayed to the end, so it shows how good it was. I think we got some questions in the chat. If we can go through them just before I let you go.
Yeah, of course.
Yeah. I go on privately, so I'll go through that one first. It was, do you wait 5 minutes after immediate dentin sealing before placing the flowable composite on the biobase?
Okay, so that's one thing. When I was reading through that, I thought that might be a slight misconception. So the 5-minute wait is after the biobase. So your immediate dentine seal, you then cure, you do your resin coat, 0.5 millimeters, cure, and then you do your 1 millimeter of composite and cure. And so theoretically, it's that you shouldn't impede 1.5 millimeters above the dentine within the first 5 minutes. But by the time you've applied your bond and cured, you've applied your resin and cured, that'll be 2 or 3 minutes. You apply your next layer, 1 millimeter of composite and cure, that might be 4.5 minutes by then. So you're only going to end up waiting maybe 30 seconds. But from the second you bonded with immediate dentine sealing to a tooth, you can start a timer or a stopwatch, and then you can add your resin coat, your 1 millimeter of composite, and then you may have passed 5 minutes by then, because it depends how quickly you work. But if you haven't, wait till it hits 5, and then that's when you can carry on with building the rest of the tooth.
Yeah, that makes sense. And we got a question from Ibrahim saying, does Caries detecting dye decrease the potential bond strength if left due to CRE rules?
No, so Caries detecting dye doesn't affect bond strength at all.
And
it increases bond. It increases bond strength because it knows, because you know where to remove the outer Caries dentine. Okay.
And can you still deactivate MMPs with a 2-stage self-etch system?
So the answer is probably yes. I'm not exactly sure what 2-stage self-etch system there is, But what can happen? So so there's two things there. I think because they're saying because it's not acidic, with a two-stage system, because the primer is the etch, are you activating the MMPs? With that, I think because it's still acidic, yes, you are. So you should still deactivate with chlorhexidine. However, there are some dentine bonding agents out there, possibly some of the ones I discussed, do actually have MMP deactivating compounds in them. But the ones that you'll be using in dental school, in a lot of practices as well, they're not gold standard bonding agents. So you'll have to deactivate with chlorhexidine yourself.
So it just depends on the one you use. I think that's what she was asking.
Yeah, but rule of thumb, I'd say, on rule of thumb, use chlorhexidine after you've etched. So etch, rinse off, chlorhexidine on a cotton wool pledget, rinse off, dry, bond.
That might be it. Have you got any questions privately? Oh no, there's a couple more at the end. Sorry. Sorry, I don't understand why you don't wait the full 5 minutes before putting the first millimeter of flow composite.
So I'll go over again. So the 5-minute theory is that as soon as you have done bond, so an immediate dentine sealing, you start a timer or you start a theoretical timer for 5 minutes. Within that first 5 minutes, if you encroach on more than 1.5 millimeters above the tooth, the center of mass within the tooth becomes the restoration, and the bond will move away from the hybrid layer, and you lose 80% the strength of the hybrid layer. So bond, start the stopwatch. So bond and light cure, start the stopwatch. Okay, and then you do your resin coat, might take a minute to do, and cure another 40 seconds, so that's a minute 40. Then do a layer of composite, 1 millimeter, that might take you a minute to place, so that's 2 minutes 40. Light cure again, 40 seconds, that's 3 minutes 20. But on top of the bond as well, that would probably be up to 4 minutes then. So then all you got to do after you've done that 1 millimeter composite is wait the 1 minute, and then you can then carry on building. So the bio base, you can build the bio base within that 5 minutes, but you can't build above that within 5 minutes.
Yeah, I think we're recording the webinar, aren't we, Niji? So we'll put it on YouTube if anyone wants to go back and watch some things that are quite complex.
We might have a couple more questions. I'll just quickly read.
Yeah, go for it.
Yeah, so someone asked, do you reapply the caries detection dye after removing the outer caries dentine, or does it soak into the IDC? Both, really. So what people do sometimes is remove the outer caries dentine, which is the bright pink color, and then it comes up with a light pink color. But when you've more or less removed what you want to remove, rinse it, and then you probably apply another layer of caries detecting dye, rinse it off, and if it's not stained anymore, then you know you've removed everything. What if you don't have light cure with different settings? Then just ignore what I said, really, and just use other methods to help increase bond strength, like bevel, deactivation, matrix patelloids, using a bio base. The ones in Manchester Dental School, Dan, do have a rampant light cure setting, so it's a slow cure start to start. It's on like the top section of the light cure, so you should be able to do that. How do we convince tutors at the DH of what we want to do after watching this lecture, i.e. use chlorhexidine after etch? Just do it. That's the thing, like, just get chlorhexidines on clinic, get it in a dapping pot and just soak some cotton wool in it. And if they say what you're doing, then just say I'm deactivating my MMPs. Well, they won't have a clue what you're doing then. If they're asking and don't know what you're doing, they don't know what you're doing, but they're not going to say don't do it. And there's evidence out there. If you type in matrix metallioes proteinases, MMPs, and reduced bond strength, there's loads of evidence. Right, another one. Have you used flowable bulk fill SDR a lot of people report a few problems. Yeah, so bulk fill is, I'm not gonna lie, I've used it in the past, but from reading into this, bulk fill is kind of dental sacrilege. Like I said, if you're filling a cavity full of bulk fill, you have total disregard to the hierarchy of bondability. Such a big mass of composite is going to shrink, and the only way it's going to shrink is away from the dentine. So you're losing your bond strength to the hybrid layer. You're getting voids in your bond to dentine, and you're going to be bonding to your enamel at the same time. And that means that your hierarchy of bondability is in play, and it's going to shrink towards the enamel. So that's why bulk fill systems don't work. So avoid bulk fill. I think you already mentioned, but is it what 1 millimeter of composite you're placing after the resin coat, ideally a dentine mimicking composite? Yeah. So ideally you want a composite that's either fiber reinforced, but if you haven't got it, you haven't got it. Not many people will. Or you want a dentine that has a similar modulus of elasticity to dentine. If you've got composites, some might say dentine replacing composite. I know in the dental school you've got dentine and enamel composites, which are the green ampules, so you could use that. That would do it well. Or just be wary. That 1 millimeter layer doesn't have to be a dentine mimicking one. It's just there to say you can reduce stress even more if you're using a dentine mimicking one, as long as you're not going over that 1 millimeter of composite on your bio base, you're fine. Okie doke. Hi, I've heard you can do IDS with Scotch bonds. What are your thoughts? Yeah, you can. So immediate dentine sealing just means sealing with a bonding agent. Scotch bond, it works, but it's not a gold standing bonding agent, so it won't work as well. That's the only thing to take into account. You might have a decent bond, but you won't have the optimal bond strength. Any more questions?
The last question I got was, do you dry chlorhexidine after using it?
Rinse.
Rinse.
So yeah, rub it in and then rinse it out. And in theory, you've deactivated the MMPs, and because you're not re-etching, you're just bonding from then, you're fine.
Nice. If there's no more questions, we'll wrap it up there. Thanks everyone for watching. Thanks again, Alex, for coming on. Next week, we've got 2 student webinars coming up with some really good topics. Have a look at our Instagram account if you want to have a look at the topics and the dates and the times and that. I think that's all. If you've got anything to add, Niji?